Yeah, so one of the presentations I had at this meeting was on duvelisib in peripheral T-cell lymphoma. So duvelisib is an oral PI3 kinase delta gamma inhibitor, and it's now FDA approved for relapsed or refractory follicular lymphoma in CLL, so low-grade B-cell lymphomas. And in the phase 1 study, the optimal dose for low-grade B-cell lymphomas was 25 twice daily, but the maximum tolerated dose of the MTD was 75 twice daily, and we had treated a cohort of T-cell lymphoma patients on that study that had about a 50% response rate. So we've been looking at extending that experience and trying to understand or better define the activity in peripheral T-cell lymphoma. One question that we had was whether 75 or the higher dose was needed. For aggressive T-cell lymphomas, there is a little more toxicity at that dose level, or could we get away with the lower dose? And the early data was a little bit conflicting. So what we presented here was the dose optimization phase from the larger or more refined, the bigger phase 2 study. And in the dose optimization phase, people were randomized to either 75 milligrams twice daily or 25 milligrams twice daily to see if there was a difference. And it turned out it looks like there was. There was a group of people at the 25 twice daily who had early progression, so they didn't get to their first evaluation, and that didn't happen at the 75 milligram dose. That did correlate with higher PK or early exposure to drug at the 75 milligram cohort. So we think going forward you probably need that early, more reliable or higher drug exposure to capture a response in patients with aggressive disease. So in the full PRIMO study, which will be another 100 patients or so, we're going to treat everyone at 75 milligrams twice daily, and then they can dose reduce to 25 twice daily to try to minimize some toxicity, but try to make sure they get that early drug exposure, which looks like it's important, maybe not as important in the low-grade B-cell lymphomas. Yeah, the toxicities were pretty much in line with what we've seen. You know, there was a big phase 1 study looking at these doses, so there is some transaminase elevation, there is some immunosuppression, which we now prophylax for, but there was no new or different safety signal in this study than what we've seen in the bigger registrational studies in other lymphomas. Yeah, I think if, you know, the end of the PRIMO study could lead to FDA approval or registration in T-cell lymphoma, and then the drug would be available, and it might need a different dosing strategy than we have for the low-grade B-cell lymphomas where it's already FDA approved. So I think that would just be another important tool for treating patients in the relapse setting. Long-term, what we're really more interested in is having a bigger impact on the overall disease course. So we're doing some combination studies where we combine it with other active agents, and eventually maybe move it as part of frontline treatment. We treat these patients with curative intent in the frontline setting, usually with combination chemotherapy. So adding drugs to that, particularly if we have active drugs, and if we can identify who's most likely to respond, we have a chance of making a better impact in the first line. So I think those are the steps that are coming, and just kind of nailing down the response rate in the relapse setting is what this study is going to do.